good morning or good afternoon, everybody. Thank you very much for joining us on this new TechNet webinar. Today, we are very happy to welcome VillageReach and JSI, and they will discuss promoting equitable health product access through supply chain design. Our three panelists today are Tapiwa Mukwashi, Mariam Zamir, and Wendy Prosser. Tapiwa Mukwashi is a senior manager in supply chain at VillageReach. He's over 15 years of experience in public and private sector supply chains and currently leads VillageReach's supply chain for community health workers programs implemented in partnership with Last Mile Health in Liberia. Mariam Zamir is a manager in health systems at VillageReach. She provides technical assistance on designing supply chains and building strong health systems. She is interested in a focus on equity to improve health systems for the most vulnerable and health finance. And finally, Wendy Prosser, she's a senior technical officer in supply chain at JSI's Immunization Center. She provides technical assistance and strategic guidance on the immunization supply chain across JSI's country teams to improve the design and management of the supply chain, create processes for data use and for decision making, and apply global best practices to the context. Tapiwa will now start with a little introduction on the webinar. Tapiwa, the floor is yours.
We will share today. And as a background, we all appreciate that from a supply chain perspective, getting products to people is key. And making sure that we have high quality health products made accessible to people and available when these are needed is what we chase. We say, no product, no program. So to allow this accessibility, we appreciate that supply chains must be adapted to be more responsive, to be more resilient to the needs of underserved populations. The supply chain focuses on ensuring that health products are made available and accessible to people everywhere, where they are, when they are needed. But in practice, we find that too many people lack access to essential health products. The constraints making these people not access the products are many. Some are on the demand side, some are on the supply side, but whichever side they are, they contribute to the inequity that's experienced. One of these factors is that supply chains sometimes fail to deliver products where they are needed. But in practice and in truth, supply chains can be adapted to make sure that the people that are not having access can actually have this access. COVID-19 is introducing a new picture where this lack of access and a heightening of the inequity is made worse. Due to COVID, many populations that were not being reached are not being reached more. Many populations that were previously being reached are currently not being reached presently. So a new global imperative is needed to ensure that health products are made available to people. When we zero in directly on vaccines, we appreciate the need to increase access to vaccines. And there was a time in the history of vaccines when there was a very steep increase. The graph shows there was a steep increase in access to vaccines, but presently we can see a stagnation. And unfortunately, this stagnation is not at 100%, it's below 100%. And it is, looking at these supply chains, we look at key statistics that help us to make decisions, that help to inform how we redesign or redeploy our supply chains. And as of last year, close to 20 million children were under-immunized. And this means they did not receive all the 3 doses of DTP. We need to think about how to reach these communities that are not being reached. We also need to consider the global trends affecting how people are changing where they are living. people are not living in the same place. It's not a constant. It's changing, and supply chains need to be adaptive to change and ensure that these people are captured. And many of the children that are failing to access health services, including the 10.4 million that have actually received zero dose, are living in communities without any access to health services. But these communities can be mapped, these communities can be identified, and it's important that supply chains adapt to ensure that those left behind are actually captured in the service provision. I just want to give us a background to VillageReach, the work we do, the geographies that we work in. Our work is primarily clustered in 3 geographies where we have our core countries, that's in the DRC, in Malawi, in Mozambique. But we can see in the graph that we have a number of countries ranging from Nigeria to Liberia, Senegal, Cote d'Ivoire, where we work in partnership with other countries. Alex indicated that I currently lead VillageReach program, the Supply Chain for Community Health Worker program, which we're implementing in partnership with Last Mile Health in Liberia. We envision a world in which everyone is the healthcare that they need to thrive, and to transform healthcare service delivery to reach the people and to enable people to thrive. We focus on, in our supply chain sense, ensuring that products get to people. Conventionally, health systems have designed supply chains using a convenience. They are conveniently designing supply chains to reach clinics, health facilities. And this is not necessarily where people receive all their services. So through the presentation that we are going to receive from Mariam, we'll get to appreciate how we can think about designing supply chains that are people-centered, that are centered on providing services to people in the places they stay, in the form that they want to receive this service. And I want to give over to Mariam, who will present the guide that we have developed to promote equitable health product access through supply chain design. Thank you, Mariam.
Thanks, Tapiwa, for this overview, and good morning, good evening to everybody. I'm Mariam, and I'll be going through a little bit through the guide before handing it over to Wendy, who will give us a practical example of how you can design supply chains in a practical setting in a country as well. So when we talk about equity and the guide that we've created, we mapped out a theory of change for promoting equity through supply chains. We do acknowledge the fact that there are many supply as well as demand side factors that lead to improving coverage and equity. There's a lot of documents and literature, et cetera, on a lot of the demand side factors, such as vaccine hesitancy, et cetera, which impact coverage and equity. But today we are specifically focused on the supply chain factors that are impacting equity and that are within sort of our purview and control to be able to mitigate. So when we talk about supply chain factors that impact equity, there are 3 outcomes that we look at. The first is access, so that immunization services are conveniently and affordably accessible for all through the public and the private sector. And we recognize that, you know, when we talk about access, there's a demand side factor as well as supply side factors as well, demand side being financial access, geographic access, et cetera. But from a supply side, it really means that where are the services located? Where is your mobile outreach session, your community health workers located? And are your supply chains working for that service delivery point that is needed? The second thing I'll highlight is that it's important to think about the public as well as the private sector service provision in this, because we recognize that a lot of the communities, especially the underserved communities, might be accessing services in the private sector as well, and traditional health programs have not necessarily looked at that. The second outcome that's important for us is around availability. So making sure that sufficient stock is available and the supply chain is responsive to demand variations at public and private health facilities again. And this is important also because once we resolve demand side factors, when a person reaches a service delivery point, they should not be turned away just because the health product or the vaccine is not available at that service location, which would further inhibit them from coming back for seeking health services. And that's why it's important to make sure that products are available. And the last one is around potency, so that vaccine and health product potency is maintained up to the point of administration, again, at public as well as private health services. This is, again, we feel very critical because you can have health products available at the service delivery point, but if they're not potent, for example, vaccines have been exposed to temperatures beyond their ideal temperatures, then you may be vaccinating kids, but they're not really receiving the immunization or protection that they need because the vaccine has lost its potency. And so these three are equally important for us. The problem that we really see, and Tapiva alluded to this, is that health supply chains, including immunization supply chains, are usually designed using a one-size-fits-all approach, and that they have not been responsive to the needs of underserved communities that are consistently under-immunized or under-reached. Even when we redesign supply chains, often we are looking at only one parameter, such as efficiency or cost minimization, which is also important. But we, again, are not specifically considering the needs of the underserved communities and how do we need to specifically cater for their needs. So based on the problem statement, there are certain challenges that each community faces, which I'll talk about in a little bit and give you an overview of how the guide actually works. But our thinking is that you are able to identify certain, once you identify what the supply chain barriers are, you can adapt your supply chains to be more responsive and promote vaccine potency, which would lead to the outcomes, and then eventually combined with other interventions, other demand side interventions as well, it would increase the coverage for underserved populations. The guide that we have created helps users and countries go through a 4-step process. The first is identifying the population. This is really focused on identifying who are the underserved populations in countries and what are their characteristics. When you talk about equity, it's very hard to generalize. We know certain groups or categories of populations are consistently under-immunized. However, even if you dig a little deeper, the urban poor in one country might look different from the urban poor people in another country, even though there may be some similarities. So that's why the first step is always, understanding the population characteristics, identifying who they are, to be able to go to step number 2, which is considering their supply chain related challenges and understanding their specific challenges in their communities. In this guide, we've outlined several challenges which the user, including governments and technical partners, are able to go through and select which ones are really relevant to them, and be able to think about mitigation strategies which impact them. The third step is around selecting mitigation strategies based on the challenges that you've created. And I'll show you an example of how the guide would work. And the fourth step is measuring the progress that you're making against mitigating those specific challenges and trying to achieve those outcomes. Our ultimate goal is to improve coverage and equity. However, those are long-term goals with a lot of other factors which are impacting it. So the measurement of progress along the way helps set some milestones which can help you see if you are moving in the right direction. So the first thing that I want to talk a little bit about is identifying your underserved population. And this is the most critical step. Our assumption and what we've seen in countries is also that countries and communities often know who are the underserved populations, or they suspect that these are the populations with low coverage rates. So they have some sense of where is it that they are not being able to deliver services. Each community faces unique challenges, and hence the strategies need to be tailored to promote equity for each of these communities. The four underserved communities that are, I think, highlighted and we see most often are the urban poor communities. We've seen that going back to what Tipe was saying, the global trend around where people live and how they live has really changed over the past couple of decades. And about 1.25 billion more people live in urban areas in Asia, and about 0.8 billion more people will live in urban areas in Africa by 2050. The second population of underserved are remote rural communities. These are areas where a lot of our traditional health programs have focused, and they continue to be underserved. So we do need to make sure that services are still being provided to them and that we are catering and adapting our supply chains for them. The third population is around conflict or security compromised areas. There have been the number of conflicts have doubled since 2010, and with 68 million people that have been displaced, and about 85% of these conflicts have been in low middle income countries as well. So we've seen a general trend of increased number of conflicts. And the last is around internally displaced people or cross-country migrant communities that have also increased over the past decade or so. One thing that I want to highlight here is that you'll see that urban and rural are geographic areas like conflict, and migrants are not geographic areas. So there may be some overlap where internally displaced people might also be urban poor. So it's not necessarily mutually exclusive. With the COVID-19 pandemic, I think our thinking would also need to evolve as and when a vaccine becomes available, and we know, or a treatment becomes available, and we find out who the target population may be. They may include adult males, which are not typically the target population for a lot of immunization programs. And so we would need to think about, who are the people that we need to target, how do we reach them, and what are the specific strategies that we need to employ for them as well. So the other thing, that I'll also mention here is that, again, in mind with the COVID-19 pandemic, it's important to think about which are, when a vaccine or treatment becomes available, we might want to focus on one of these populations more than the other. The urban poor one is one that comes to my mind most immediately, primarily because of the fact that they have such dense living conditions and they're not able to practice social or physical distancing. They have usually very poor access to clean water and sanitation as well, which increases the spread of disease even further. And at the same time, because a lot of them are daily wage workers, the economic burden for them is even higher. So it's important to think about preparing your supply chains now and thinking about adapting your supply chains now as we prepare for a new vaccine or treatment in the next year. So the guide walks you through a list of challenges that we have investigated and outlined that impact supply chains. The guide works as mostly a dynamic, clickable version, so you're not meant to go through it step by step, but you can click through which ones are the most relevant for you and the populations that you work with. I'll quickly go over all the challenges that are listed here, but I don't think we will have the time to go through any or each of them in detail. But I'll encourage you to go through the guide and look at them and explore this on your own. The first one is around lack of accurate population or consumption data. So if you don't know who the people are, where they're at, it's hard to plan for your supply chains and make sure that you're ordering specific quantities and meeting the demand that they may have. The second is around lack of functional or sufficient cold chain equipment for storage as well as transportation, which can lead to loss of potency of the health product. The third is around lack of transport and poor road infrastructure, which can limit resupplying of stock, but also limits access of services by communities. The next one is around lack of physical infrastructure at service delivery points, such as electricity or equipment. So you don't really have a place to store any of the stock or health products that you want. The next is around weak procurement and distribution processes at the national level, which can lead to stockouts at lower levels of the system. This is not really referring to global shortages, but just in terms of streamlining the procurement processes at higher levels of the system, and making sure the supply chain is doing enough procurement. The next is delayed disbursement of and lack of transparency of use of funds, which can result in delayed immunization activities. The one after that is siloed health programs, which can lead to missed opportunities for vaccinations, as we know, but from a specific supply chain perspective, it also leads to multiple trips by service delivery staff, who may be going one day to pick up malaria products and the next day they'll go to pick up immunization products. And that's all the time that, they are spending on supply chain that is taken away from actually delivering the services to people. Next one is around high actual and opportunity costs, such as long travel times, distances, wait times for people to access immunization services. So again, how can we make the services closer to where the people are, and so that they're able to access it more easily and make sure that supply chains actually work for them. The next one is weak regulation of and lack of integration of private service delivery points into the immunization programs, or EPI, which can result in limited oversight on procurement, as well as around coverage data. Typically, a lot of our health programs focus on public service delivery points, but as I mentioned before, we do see information and data that a lot of the underserved communities do access services in the private sector, depending on the country that you're in. The next is around insufficient health workforce and weak health worker motivation, as well as around making sure that health workers at service delivery points are regularly trained in immunization, supply chain, and logistics. And the second last one focuses on insufficient funds for operating fixed, mobile, and outreach service delivery. If there is insufficient funding available, it results in high costs for populations in accessing services. Because the service delivery point still needs to make sure that their supply chain is operating and they are able to pay for it. And so they will then charge populations for this if they don't have funding from the system. And the last is around a compromised security area where you are not able to deliver supplies, and as well as having a shortage of health workers. So sorry for running through this very quickly, but in the interest of time, I'll maybe pick one and walk you through how you could use this guidance and make decisions and think about how you would mitigate some of these challenges in the context that you're working in. And like I mentioned before, this is a clickable guide, so you would look at all the challenges and assess based on your own underserved populations which one is the most relevant for you, and select them and look at and review the strategies for mitigating them. The one that I want to talk about today is the weak regulation of and lack of integration of the private service delivery points in EPI. And you are able to, in this guide that we've created, be able to click that, and it will take you to that specific challenge, which is organized with the challenge on top, as well as with strategies and outcomes and indicators to measure. So on the left-hand side, you see that we've outlined several strategies that you can use to address this challenge. This is by no way an exhaustive list of strategies that you can use. If you have more, we would love to hear from you and add to this as well. But these are ones that we have either used or researched or heard from stakeholders that these are ones that actually help them be able to mitigate that specific challenge. So let me pick one. I'll pick the second one. For example, the second one is talks about including private providers in immunization supply chains to provide consistent WHO pre-qualified vaccines at more locations and ensuring safe vaccine handling and delivery during transport. In a lot of countries, still, where the private sector, the private service delivery points run their own parallel supply chains, and they're often individual supply chains where they may procure from wherever they want. There's very little regulation of which vaccines they're procuring, how are they being stored, et cetera, all of that. And if the government starts working with them and contracting with private providers on this, also probably supplying them the health products that they need, then we can ensure that one, the products that they are using are WHO pre-qualified, there's safe handling for transportation, and that they're being stored in the appropriate ways. And this will lead to us improving our outcomes of access as well as potency, because we can make sure that the private providers have the products that they need, and that improves access for people who may be accessing services in the private service delivery space. And there is also a little bit more oversight around maintaining the potency of the products up to the point of administration. The third section that you see on the right-hand side lists out certain indicators that you can use to see if you are making progress around mitigating this challenge as well as achieving your outcomes. And the way this document is laid out, if you reviewed this challenge, you can go back to the main challenges page. You just click on it and you're able to go back. But I'll show you an example of what one of the indicators actually looks like, such as reliable sourcing of products for private service delivery. And here we outline and also call out if it's a priority for a certain area or not. So you don't have to measure these indicators for all possible populations, for all possible programs, but specifically related to where you're working. This is an example of where what an indicator looks like. It outlines the definition or formula of how you would actually calculate it, what is the data that you need. It explains the rationale for why this indicator, why we have selected this indicator and why we think this indicator is important. And it's up to the user to assess and decide if it's relevant in their context, but the rationale as well as the sources for more information provides context, and all the indicators have been very, very carefully selected. We also provide guidance on how to measure the indicator as well as the target for each of the indicator. A lot of the indicators have targets, not all of them. So for example, this one you see does not have a specific finite numerical target. But we encourage countries to come up with a country-specific target that they define with stakeholders within themselves, just because there's so much variation in how private service delivery works for this specific indicator. But a lot of them have very concrete specific targets as well. After reviewing this, you can again go back to the challenges to see and select another one. Again, in the interest of time, like I said, we are only going to be looking at one. You are also able to go and see a complete list of all the indicators that are there. And this is a list of 24 or so indicators that we have mapped out, which map to each of the outcomes that I talked about initially, as well as highlights where for which populations it should be a priority. And so provides guidance to users on how and where to use them. I'm going to skip over this and maybe just talk a little bit about some of the resources that are available related to equity and immunization that is there. The first link is for the equity reference group. This is a high-level group between a couple of global partners that have some very interesting papers that talk about some of the aspects and as well as populations in a lot more detail. They touch on supply chain, but it's not supply chain focused. So if you're looking for a more holistic overview, or if you're looking for other non-supply or demand side related factors, this is a good resource to look at. The second is the urban immunization toolkit that Gabby has created, which specifically looks at the factors that impact immunization in urban areas. The third is when we initially started this work around immunization and supply chain design, we actually started with a country setting and looked at this. We were doing supply chain design work in Pakistan, and then looked at how do you promote equity while doing supply chain design. So there is a paper available on that, and how did we look at that? What metrics did we do? What changes did we make to the supply chain design, which we've included in this guide, but that's another practical example as well. I've also added links to the guide that is available on TechNet, as well as a short two-pager on how the guide works. I will now hand it over to my colleague, Wendy, who will talk about a specific example in Haiti and how they looked at supply chain and modified their supply chain design for equity.
Great.
Over to you, Wendy.
Thank you. And I'm bringing up the slides now. Okay, and so I wanted to just give a practical example of how this kind of plays out in reality. JSI is a global health consulting firm, and we have specific centers working in immunization and supply chain, and so we bring them together in this type of work. This example comes from Cité Soleil in Haiti, which is known as one of the most notorious slums in the world. So it addresses a lot of the issues that Miriam was discussing about the poor lack of infrastructure, the floods, the open sewers, insecurity. It's within the city of Port-au-Prince. And you can see that one of the, oh, sorry about this, that it's one of the lowest coverage rates for immunization out of all these communes in Port-au-Prince. One of the, of course, very weak health system. And one of the issues with the security, the insecurity part, is the district level EPI managers don't feel comfortable even delivering vaccines. And this was one of the issues that came up. And so there was a service and community assessment that was done that identified several of these reasons for low coverage. Some were the supply chain related, with inadequate stock amounts, frequent stockouts, and insufficient cold chain capacity. There were long wait times at the facilities. Clients were not happy with the treatment that they received by healthcare workers. Poor data quality reporting. The target population was inaccurate, which is often the case in many of these situations, and the insecurity. And what JSI did is had these six critical interrelated components approach to strengthening immunization services, looking at the governance structure, human resources, service delivery aspect, community engagement, monitoring use of data, and finally the logistics and supply chain component. And clearly there are many components and many aspects that influence immunization uptake and immunization coverage. Today, we want to focus on the logistics and supply chain aspect and just link it to the equity and service delivery. So essentially, there was not enough stock and there was no place to keep it. Here, just a quick high-level overview of the quantities of vaccines that were delivered in those 3 years, the rotavirus vaccine and measles rubella. You can see the target population, and compared to the actual quantities of vaccines that were available and delivered to these specific areas, it falls short. And there are also no cold chain equipment available. Largely because of the insecurity, they couldn't keep equipment safe there. And so health workers were required to go fetch vaccines. It's not safe to travel. And it was largely dependent on a health worker going and having vaccines available for the day for the immunization session, but there was no way to keep them for longer term. So through this process and community engagement, we identified some key interventions for supply chain. Working with the Ministry of Health, working with the local community. The first thing is reviewing and updating the bottom-up microplans. So this addressed the inaccurate target population, which was the first to really understand exactly what the need is. And they identified target population in that catchment area, specifically because it was, as Miriam explained, a lot of people moving around. Urban slums are unknown of the true population that needs the services. We also shifted from a target-based forecasting to consumption-based because the target population was so inaccurate, looking more at the consumption-based, adjusting over time, which comes up in a later bullet. Weekly text messages and phone calls, so just better communication between the cold store and the health centers to ensure that the quantities of vaccines are available and at the facility when it's needed. Improved capacity on stock management and cold chain maintenance through coaching and mentoring. So this involved just better data, better use of data, stock management, tracking what's required, what's needed, ensuring that they get resupplied, either go to collect or get delivered. The cold chain, the solar refrigerator, this was a big part of improving the overall performance of the supply chain. As UNICEF installed a solar refrigerator, and they identified a safe place to keep it that's secure. And over the couple years, seeing the demand increase, they also installed 4 more cold chain equipment because moms were coming more. There was a higher demand. The facility understood exactly how many people they were serving. And so the demand justified, the evidence justified additional cold chain equipment to ensure product availability. And then finally, the last point is probably one of the most important, is the community engagement. And as Miriam pointed out, the community knows where the populations are being missed, right? They understand their community, they understand the kids that are not coming for services. And so this community engagement was an important part to identify these interventions, but also identify the issues and solutions and understand the real problems. And through this continuous engagement with the community leaders, there is involvement to make sure the health facilities are safe, to make sure the health workers are safe, to make sure moms are safe when they come to the centers for vaccines for their babies, and to ensure that there is a collaborative approach to reduce the risk of violence to people coming to the community, to the facility. And on the graph, you can see the improved availability of vaccines just from these. It's paying attention more to the details, right? So it's looking at the equity, recognizing that there is an issue, identifying the problems that led to these issues in the supply chain performance, and then addressing that little by little through a collaborative approach. And at the end of the day, you can see their vaccine coverage rate also increased. This is not to say that supply chain is the silver bullet, because of course there are many other influences on demand, but having vaccines available is one of the influences, one of the first steps of having higher coverage. And through this approach in supply chain management, identifying the real issues, this is where we are today. So that is just a quick overview. I think we can now open it up to questions.
Great, so we have Jenny with us that I'm going to welcome as a panelist. So Jenny is now a panelist. So Jenny is going to take care of questions and answers. Jenny, you're on mute. The floor is yours.
Excellent, great. So to start, Wendy, you touched on this a little bit, but can you and Mariam say more about what administrative levels and for which components of the supply chain you consider adaptations?
Yeah, that's a great question. When people start, I feel like when we talk about supply chain design, it could be everything from national level all the way to the mobile brigades and outreach. Or you can also look at different levels and different segments of the population, segments of the supply chain. So in the case from Haiti and Cirque du Soleil, it was one commune. It was a very tailored approach. And again, that kind of reiterates what Miriam was talking about, that it does need to be a tailored approach to that specific context. Other design aspects can look at how the flow of product goes from national to the facility level. It could also be different components of the supply chain. So some could look at just the transport, or just the LMIS, or just the cold rooms themselves. So it's when you're looking at system design or any kind of design of the supply chain, it could be an overhaul or this tailored approach that really could address some of the equity issues in it.
Yeah, and I'll just add and say, you know, going back to some of the challenges that I spoke about, it really, some of them are at very, very different levels. So it's hard to, it really depends on your context and the challenge that you're facing. So some of the challenges that are sometimes faced is at a national level, if your procurement processes, for example, are not aligned, they will lead to stockouts at lower levels of the system, even if your supply chain is functioning amazingly at lower levels of the system, but there's some issues at national level. Versus also, you know, looking at making sure that your financing is available to actually make sure that the supply chain is working at lower levels of the system. Again, that speaks to some of the higher level challenges that you see in the system versus challenges at lower levels of the system, such as, you know, making sure that the mobile outreach actually happens and the products actually get there. So it can be at any level that you look at and really should be looked at in the context of your country.
Great, that's fantastic, thanks. And how do we as a supply chain community support governments to strengthen the resilience and adaptability of supply chains?
Who wants to take that one? I bet we all have opinions on that, I think. And I think our role is really working with the government, and Miriam just kind of spoke about this as well, working with the government to see what works in that context and to strengthen the government-supported supply chains, bringing in the private sector, as Miriam talked about, that it needs to be coordinated, and strengthening some of it's the nuts and bolts of supply chain management, and some of it's the bigger picture of the design and thinking a bit broader than just filling out a stock ledger form, right? There are different approaches to looking at your supply chain, designing and then managing your supply chain. And I think our role is to really support and strengthen both the nuts and bolts of the daily management of supply chain, as well as the bigger picture of thinking design and how to really create efficient supply chains that address the equity issues as well. Miriam, I'm sure you have more to add.
Yeah, no, I completely agree. I think, you know, when we go in and support countries to do supply chain design, I think we often try to take direction from the countries and understand what the priorities for the government are. And that's always the first step in trying to make sure that we understand what their priorities are, where they're coming from, what their underserved populations are. So it differs a little bit across, but, you know, working closely with them in trying to make sure that we're putting systems in place. These are not one-off, like, okay, we'll, you know, change small things in your supply chain. Sometimes it's small, sometimes it's not. It really is looking at the overall design to build that resilience in the system, as well as looking at it very holistically and not just focusing on one or the other aspects. And again, that's why I think when we were putting the guide together, we tried to look at it from all aspects of the health system. So it does look at sort of the human resource component, the financing component. Wendy talked about some of the community engagement components as well. And that's what really builds a resilient system.
Excellent. There was one question in the chat that Tapia was responded to a little bit, but Mariam and Tapia, maybe you both want to say something else about this. When designing for equity, are there some more standard SC indicators that can be leveraged to analyze equity issues within supply chains, or does supply chain design for equity depend mostly on special assessments that must be conducted?
Thanks, Jenny. So before Mariam gives a more detailed response, because at some point in the presentation, she gave a detailed outline of the different metrics that could be used to give an impression on equity. I just highlighted some three very important considerations in terms of metrics that were used in this particular example, and one is looking at the cold chain coverage and relating the cold chain coverage per fully immunized child to the ability of the system to store sufficient vaccines to save populations. And there were two metrics that were related to distance. One on the average resupply distance of vaccines between the health facility and the resupply store, and the other on inbound resupply distance of vaccines between districts thrown in the next level system, because these have an impact on the potency and quality of the vaccine. So I just generalized these three to give a broader overview, but Mariam has provided the true and specific metrics that can be further broken down on cold chain, on distance, access, etc.
Yeah, and I will just add, I think for supply chain there, for immunization supply chain, we do have a list of 7 DISC indicators that we look at, and they have been included in the indicator list that I mentioned as well. And those are standard indicators for supply chain that we look at. I think the one thing that I do want to highlight is that, you know, I'm not 100%, I don't want to call it like a special assessment, because equity is a lens that you take. I think one of the things that you should try and avoid doing is make equity its own separate program and its own separate vertical, which, you know, somebody is in a separate department is managing and handling. It really needs to be well integrated with whatever work that you are doing and considering the needs of the specific populations that you are working with. If you're doing a supply chain design exercise, or if you are making some changes, or if you need to improve coverage, like for example, if a COVID vaccine is introduced, you might not be redesigning your whole supply chain, but you might be thinking about, you know, how do you introduce new vaccines? And so it's important to think about and bring that extra lens and extra, you know, perspective to say, how can we make sure that we're getting to the underserved population? Who is my underserved population that this vaccine, this COVID-19 vaccine needs to get to? How do I make sure that I can actually get to them and be able to, you know, make sure that they're able to access it, there's availability, and the vaccine is potent. It's not something, in my view at least, that is something which is done sort of on the side. Specifically for our country, but it's very well integrated with the programs that you are already running.
Mariam, I just wanted to add where you use the term in equity lens, just to highlight that for the most part, system design will have an objective, and the objective has traditionally been on cost efficiency. And if cost is the only consideration, a supply chain system will be designed to ensure that products are delivered at those locations that provide for the least optimal cost in a system. And this equity lens says this is good, but this is not enough. You need to add an additional lens to help you see how, after achieving cost efficiency, you capture an integral populations that have been missed by this system design.
Yeah, absolutely. And I think, you know, I think cost is an interesting question. There are other goals that you can have when you're designing your system. Cost is the one that we most often use. And cost is important also because you need money to be able to invest in, you know, maybe reaching your underserved population requires a higher investment in cost for a smaller population cluster or smaller population category for which you need money to do it. And so no one is, I think, denying the importance of cost. So you do need that, but you have to also sort of weigh it with, you know, equity. And it's not always that equity interventions are more expensive. Some of it is very in line. They can be cost saving as well. Delivering products directly to a health facility is an interesting one where you know, you can have the district or a province deliver products directly to the health facility in a van, which reduces and consolidates a lot of the transportation, but will also improve equity in terms of having the health workers spend less time in supply chain and logistics, less time traveling, potentially less temperature excursions, and that they have more time spent on actually delivering the services to people.
Great. I think you're starting to get into this, Mariam, but another question. Can you elaborate more on how integration with other commodities helps to boost equity? Maybe you and Tapiwa can both comment on that.
I'll let Mariam handle that one.
Could you repeat that one, Jenny?
Yeah, can you elaborate more on how integration with other commodities helps to boost equity?
Yeah, I think that's a tricky one. I'm sure Wendy has something to say on this too. So with the integration of commodities, potentially you would reduce your cost as well, because you are consolidating a lot of the time as well as money and resources that are spent on transportation, as well as on inventory and as well as on data systems. So that leads to efficiencies, which translate to the lower levels of the health system. I think the other way to look at it is also that at the lower levels of the system, usually the health worker is responsible for all of the products anyway. You don't normally have one health worker working on each different product, so it helps them consolidate a lot of the work that they are doing. And so that leads to cost efficiency, which you can then improve and invest in equity. An example that I'll give you is one from Malawi. When we were visiting one of the health centers, is that vaccines had their own supply chain, and all the other health products had their own supply chain. So all the other health products were being delivered by the district or the other facility directly to the health facility, but not the vaccines. The vaccines the health worker had to go on his bike, and whichever season it was, and he had to go to the upstream facility to be able to pick it up. So while there were all the other products that were available at the health facility, the health worker may or may not be able to go to collect vaccines specifically if it was extremely rainy, if the road was really bad, if his bike wasn't working, or if he was too busy. Which led to stockouts for vaccines. So if a mother is coming for services, she may be able to get all the other services that she needs, but she's not able to get vaccines. And will they come back for another visit when the vaccine is available? It's highly unlikely that they would be able to do that. Mm-hmm. I'm sure Wendy, you have something to say.
Mm-hmm. So yeah, I just wanted to add, Mariam. So one of the other disincentives to providing products to sparsely populated populations is just how little volumes, how the challenges of delivering very little volumes in hard to reach areas in sparsely populated populations. So integration allows for aggregation of commodities, right? So they are sharing storage space, they are sharing distribution assets, and you are able to aggregate sufficient volumes to justify providing services or taking products to populations that are in difficult places to reach. You will also see that with integration, there are commodities that can share cold chain facilities. And while it is very difficult to establish cold chain facilities for very small populations, if you are going to be integrating products and having them share those shared facilities, you can achieve some economies of scale that allows supply chains to reach further than they are currently reaching.
And just to build on that a little bit, it also has a public health perspective that, for example, the oxytocin is a perfect example of how that could be integrated into the vaccine supply chain. It has tremendous public health benefits for the mom that then leads to having a better life for the child. And in that type of sense, that you have the equity from the supply chain perspective, but also the benefits on the public health side of things with an integrated supply chain. Another opportunity to boost equity.
Yeah. I think one other thing I'll mention is in the context of the current COVID-19 pandemic, there's been a recent statement that's been released in terms of, cold chain being shared for products. So when a COVID-19 vaccine or treatment becomes available, instead of trying to reestablish that entire system, being able to use resources across programs to make sure that the products really get to where they are needed in the fastest way possible.
Okay, right. It's 5 o'clock, I see. I don't know. Do you have maybe 1 or 2 more minutes to answer, like quickly, some maybe remaining questions?
Sure.
Yeah. Jenny, do you have remaining questions?
No, we're through everything in the
All right.
Q&A box.
Okay, good.
There was a couple in the webinar chat around checking for potency for vaccines, and there are a lot of vaccines now have the VVM, and also the shake test for the freezing is available to truly check potency. It usually has to be sent back to the manufacturer, which is a lot of most often out of the reach of countries to do that. And that just makes the case for having a strong, reliable, flexible, adaptive supply chain to ensure cold chain throughout the supply chain. That'd be the only thing I would add.
Yeah.
Okay, excellent.
Yeah,
There was like, sorry, go ahead.
I was going to say, and I think, you know, to me, that really goes back to some of the health worker portion in terms of either training and logistics, et cetera, all that, because we can solve the technology, but you also have to look at it from a system perspective, and make sure that, you know, even if there's a VVM available, that people know how to read it and access it and be able to record that information.
Yep. All right, so I think we need to wrap up. It's 5:02. Thank you very much for this excellent presentation. We're going to share the slides as well as this video that is recorded, and it will be available on TechNet, and we'll write a link on the forum so that you can find everything directly from there. Thanks again, Wendy, Miriam, Tapiwa, Jenny, and I wish you all a wonderful day or evening, and hopefully talk to you soon. Bye-bye.
Thanks, everyone. Stay safe.
Thank you. Bye-bye.
Bye-bye.